Hello everyone. This is Dr. Yamal Patel from Third Park Hospital in Nairobi, Kenya. Today we are going to be discussing a very important topic, and we are going to do this in the form of an actual demonstration so that it's easier to grasp and understand. We're going to be discussing electrosurgery. So as we go into electrosurgery, let's first start with electricity. What is electricity? It is a form of energy like thermal energy, mechanical energy, kinetic energy, potential energy. So different types of energy. And we all know that energy cannot be destroyed, but it can be changed from one form to another. So a few things about electricity that we need to understand very clearly is, number one, it will always follow the path of least resistance. Number two, it will always seek ground. Number three, it must have a complete circuit to work. So if there's a break in a circuit, we'll be discussing this, then the electricity stops going through. A few words that I want us to understand as we go on into this demonstration today is, in terminology, we need to understand 3 or 4 things that are very important for us. Number one, current. Number two, voltage. Number three, circuit. Number four, frequency. And number 5, resistance or impedance. So we'll start off with this electrosurgery demonstration by going through some of these things. Before we move on, let's go into what is electrosurgery versus electrocautery. Electrosurgery can be called diathermy, but it is not the same as electrocautery. Electrocautery is where we would use direct current to heat an electrode and then use that hot electrode to go and burn a tissue, like branding of animals. So in branding of animals, you heat it directly on fire. Here you can use electricity to heat the electrode and then go and burn. That's not what we exactly do in electrosurgery. Electrosurgery or diathermy is where we are using alternating current that passes through the electrode. In this case, could be an instrument or any electrode, through the tissue of interest and then to heat the tissue of interest. That is electrosurgery. And we are using it to our benefit to burn the tissue so that we can stop bleeding or use it for hemostasis. So let's go through these one by one. Frequency. Now, it's important that we understand what is the frequency of this electricity that we are using. So if you look at these sockets that we have in our houses, let's understand the socket has a voltage of 210 volts in a country like ours, but it could be 110 volts in a country like the US. So that's the voltage. Then we have the frequency, which is around 60 hertz. So 60 cycles per second is the frequency of that electricity. Now, we are not able, none of us is able to put in a finger or an instrument which is a conductor into that socket. Why? Because we would get a shock. So what is a shock? A shock is where we get Faradic or neuromuscular stimulation. So you put it in and you get neuromuscular stimulation. And if not immediately stopped, that can also cause an interference with our electrical impulses in our heart and therefore can cause an arrest. So we don't have the guts to put in and get interfered with by electricity at 60 hertz. Now this same electricity, when the frequency goes up slowly to a frequency of around 100 kilohertz, so which is 100,000 hertz, 100,000 cycles per second, then the neuromuscular stimulation stops. And above that, what we get is actually heat. So that electricity will be transformed into heat, which we use for our benefit to do our surgery. So this machine, this is one of the machines that we would call an electrosurgical unit, ESU. We have them from different companies, and all the companies work on similar principles. So this we've just gotten for a demonstration purpose. So this ESU converts, when it's connected to the power, it converts the low frequency, high voltage current into a high frequency alternating current. So which is, it causes that 60 hertz to go over 100 kilohertz. The regular range that we use is between 350 to 500 kilohertz. So the output from this instrument is now 350,000 to 500,000 cycles per second. So this is what we would use to cause electricity. Now, to cause the burn. So you can see here, so you can see that I'm actually burning. So when I'm actually activating it, you can see, use the light here, so you can see this. So okay, so you can actually see that it actually causes electricity. So now I am not using gloves. Look at what I'm trying to tell you. I'm not using gloves and I'm still not getting electrocuted. But the reason is this machine has changed it to heat energy, and it is not electrical energy that is stimulating to my neuromuscular muscle or elements. So I don't get a stimulation now. So this is what we were talking about when using the electricity to cause energy. Now we move on further to understand that we can have two types of circuits that we use for our energy. So the first energy circuit that we use is the monopolar electrosurgical circuit. So what is monopolar? Here, Humphrey. So monopolar is, now let's understand this. Monopolar is in to activate the machine using the regular household electricity, out from here into this cable and into the instrument. From the instrument, disconnected. From the instrument, this is our patient, the lemon is our patient, into the patient, so you see, to get whatever effect you want. Out from the patient into this return or dispersive electrode. From the return or dispersive electrode, the cable goes back in and back to the machine to complete the circuit. So that is a monopolar circuit. Now, if I disconnect this, or if there is a poor contact between this and this, you will immediately stop the circuit. Bring the other dispersive electrode. So the dispersive electrodes are of different types. I want us to understand a few things. We have this regular dispersive electrode. We have a metal dispersive electrode. And we have this dual dispersive electrode, which is a split electrode. And it actually has two separate dispersive electrodes. These are both conductors and they are both separate, and then they are connected here to return back. Now this is the one that is the latest or the most secure, because if there is a disconnection of one of them, this machine will stop working. This is the older one, so you have higher risk of issues about stray current with this, but with this one it would reduce. However, we'll demonstrate that as we move on. For demonstration purposes, it might be easier to work with this because that will keep on stopping to work. So now we go on. We'll go into the settings later. So we are looking at a few things about the electrosurgery. So monopolar circuit. Number one, when we talk of return electrode, we'll go into the variables that actually affect the tissue effect that we want. So what are the different tissue effects that we can get? Number one, we can get an effect called cut, which we know as cut, or it's called vaporization. We can get an effect called coagulation or desiccation. We can get an effect that is blend in between the two, or fulgurate. So this is the fulgurate effect. Now, that is not the same as the waveforms. So in the waveforms, when you come here, this same machine is giving you the monopolar side and the bipolar side. In the monopolar side, we have the cut, the coag, and it will have a blend in some of these machines. So what is the cut? This cut is not equivalent to the cut effect. Please, let's not mix these two things up. The cut mode is not the same as cut effect. So for today's practical, we would call this cut, and we would call that effect as vaporize, okay? For today's practical class, we will call this coag mode, and we would call what we get as an effect there as desiccate, okay? Or fulgurate. So we are not going to use this and that interchangeably, because that's where people get confused. So what is cut mode? The cut mode is undampened. It is like a sine wave. It is low voltage. It is continuous, which means it is active almost 96 to 100% of the times that I press the button, that foot switch, and it is low risk. So one very categorical statement: high voltage means faster work, but high voltage means dangerous. So we don't want to do dangerous work inside our patient. So we have to therefore stick to the lower voltage, which is the cut mode. The cut mode is the lower voltage. So what is the coagulation mode? The coagulation mode is high voltage. It is on and off, like a spark on and off, and it is high risk. The voltage that actually it goes to in this coag is actually up to 6,000 volts. So you can imagine what a 6,000 volt would feel like on a patient. It is like a lightning strike. So it's actually very dangerous if you're not careful using the blue button. So please, let's not understand yellow button as the button to cut with and blue as the button to coagulate with. That is wrong. I will clarify that as we move on. And the third one, the mode, is the blend. In the blend mode, you get what is called the current starting to be interrupted slowly. So the cut is non-interrupted, and the coagulation is completely interrupted with only 4% of the times that actually the current is going through the electrode when you press the blue. So when you press the blue for 10 seconds, the current has gone in once, twice, thrice, but very high voltage. That's the problem. So it's like a spark on and spark off, or like a lightning strike and off. Whereas in blend now, you start getting a little bit of more dampening, but not completely undampened. And the voltage slowly starts rising from the cut towards the coagulation. So that is what we get. And it is important that we know where to use this kind of a current. So where to use cut, where to use coagulation mode, and where to use blend mode, we will discuss towards the end of this class. Now, when we go into the variables that now affect the tissue effect that we want there. Number one, it's the waveform. So which mode or which waveform are we using? Is it the cut, the yellow? Is it the coag, the blue? Or is it a blend which is in between the two? The second thing that affects the tissue effect is the electrode size or the surface area. Now, what do I mean by that? Now, you see this. This is an electrode that will take the electricity into this patient, and this is an electrode that will take the electricity out of the patient. Okay? So what do I mean now? You can see. When I activate it, it is burning here. Am I right? Can you see? It burns and it gives you the effect you want. So that is with the blue, and that is with the yellow. Both of them have been used to cut, but there is a difference between the two because the blue is going to cause a lot of lateral thermal spread as well because it's a very high voltage current. So this is what would happen with the electrode size. Now, the same electricity, if I remember, I told you in the starting just now that electricity cannot be damaged. It cannot be destroyed. So energy, that is electricity, changed into thermal. It burnt the patient here, but it did not burn the patient here. Why? Because the in was narrow and it burnt. The out is broad, this broad, and it did not burn. Are we understanding there? So let's now change this a bit. Now see here, I've changed this a bit where I'm now putting it in a different way. Now I want you to look here. You will see a burn here and watch under this place as well. Okay, so can you see the burning? Now what did you see? You saw a burn under. Agreed? I'm repeating it again. Please have a look. Burn here and burn under. Look at that. So what did this tell you? It's the same patient, but now you have a burn here. Why do you have a burn here? Because the in was narrow and it burnt here. The out was narrow. It burnt here. So this is something we need to keep in mind, and we will give you the guidelines as to how therefore to apply this so that you don't get a narrow out. Please now, one dictum. Narrow in will cause a burn. Narrow out will cause a burn. Narrow in will cause a burn. Broad out will not cause a burn. Why am I not getting burnt? Because I am holding it broad. Look at this. Can you see that? Now, if I do this and activate the same thing, this is narrow out, I will get burnt. So this is where, this is what I was saying. I'm not doing any magic here, but I understand the principles. Narrow in, it will burn. Broad out, no burn. Okay? So that is a second tissue effect I want us to understand. The third one that changes the effect we get is the rate of the cut. So what do I mean? If I go in here and I now activate it and I cut, see, that's a cut. I go in here and I go slowly. So see, they have both cut. But this has cut like a knife, a smooth knife, and this has cut with a lot of burning on the side. So that is the rate at which you're moving your electrode will also cause the effect to change. The third one is the duration of the contact. So that is rate at speed or duration of contact. Then the next one is contact versus no contact. So what do I mean? Look at this. When I activate it, with the yellow in this, I am going to be using yellow most of the times. So when I activate it, I leave a space between the patient and the electrode, and I activate it, and then I cut, and it cuts like butter. But when I go and touch this, and then I activate it, see, it gets stuck. It gets stuck. So this is the problem. So when you want to actually cut tissue, like here, put this there. So when you want to cut this tissue, see, Now that's a very nice cut. Whereas when I use the blue, now you can see very clearly, if you can focus here, you can see that this tissue with the blue has caused a lot of lateral thermal spread, whereas with the cut, it is actually cut very neatly. So what I was saying about contact and non-contact, when you want to cut or vaporize, we said vaporize, then you leave a space and cut. See, it cuts like a knife. If you can see, very nice, no burning of the surrounding tissue. But when I now go the same mode, the same yellow mode, and I go and touch and then activate it, it will cut, but it has now caused burning on the surrounding structures. So the difference in the two now is, in one of them you are doing contact electrosurgery, in the second one you're doing non-contact electrosurgery. For cutting, the non-contact electrosurgery is the most effective, okay? For the coagulation or for desiccating a tissue, the contact is what you would need. The next thing is surface area. So this same electrode, in when I used it straight, is cutting. Whereas when I use it, I just turn it about and I now do this. So I've changed the surface area. You can see in one it is coagulating, in one it is cutting. So that effect is not dependent on the mode as much as it is dependent on these other factors. The speed, the way you orient it, the time spent on the tissue, the rate of the current, the setting of the current, the type of tissue. This tissue has less resistance than this tissue, and that the power setting. The last one is the eschar tissue. So you see, when you get this buildup of the eschar or the black carbonization tissue, it has to be cleaned, because without cleaning this, you will get this tissue sticking to that. So this is about the effects of electrosurgery on the patient's tissues, okay? Now, the next thing that I want us to be very clear about is about resistance. Yeah. So I told you this resistance is different from this resistance, is different from this resistance. This is dry tissue. This is having a lot of fluid, and this is, put it back here. This is actually the tissue that is closest to our tissue, and therefore the effect is best seen on this tissue, okay? So least resistance, medium resistance, highest resistance among these three. When we go to our body tissues, the fat has more resistance than muscle tissue. The viscera has least resistance. So bowel, liver tissue has actually the least resistance. Scar tissue has the highest resistance. So scar or dry tissue has high resistance, even above fat. So when you're cutting through scar tissue, you will take longer to cut it than through fat, which will be longer than through muscle, which will be longer than through liver or the bowel. So that's important to understand as well. And also, dry tissue has more resistance than wet tissue. So when you have tissue that is a bit moist, it will cut faster than when it is dried out tissue. Okay? So let's go back to a few guidelines about the electrosurgical return or dispersive electrode. Get me that return electrode. So some of the rules about this. Number one, don't alter the size. So you have to use the right size for the right patient. This is the size for an average adult. For obese patient, you may need a bigger one than this. The second one is for younger children, pediatric might be smaller than this, and neonates might be a very small return electrode. So try not to use the wrong sized electrode. Secondly, try not to alter the sizes. So if it doesn't fit, you don't cut this to make it smaller. It doesn't work that way. You have to get the right size. Third one, when you use this, it has to be well applied. So it means it has to have good contact. So if you're using this, it has glue here, which you will use to attach to your body. So important thing, number one, it should be well applied without tenting. So it can't be like this. This is tenting. You don't know tenting here. The next rule is it has to be applied across so that the widest surface is the one closest to the site of surgery. So one rule, it has to be closest to the surgical site. So when you're operating in the pelvis or in the abdomen, the closest site would be the gluteal or the thigh, and can go up to here, but don't go very far. This would be probably better. Third thing is you put it in such a way that the widest surface is actually facing the site of surgery. So this is wrong. This is definitely very wrong, because the closest surface is this point here. Now what happens is, when you, please put it just put it on yourself in a side. Just don't open it, just like that. So let's say that way. Let's say I'm operating here, and this is how I said it should be. Okay? So you're operating here, the electricity goes like that to this dispersive electrode. So you get fine in, electric burn, broad out, no burn. You change it this way, fine in, and then the electricity will always find, I told you, the least resistance and the closest point. The electricity is not your friend. So it's not going to say, poor guy, he didn't know what he was doing, so let me go and distribute myself across. No, it might actually start going to the closest point of exit, which in this case is this point. So you'll get a fine in with a burn and a fine out with a burn here. So when you remove this later, there is a burn here. Not allowed to change that position. Same with this. This is fine in, but this is still not, it will heat up here. So it's not still the best way. The best way is across. So please remember that. Another rule is that it has to be, if it is something like this, you will put it round and you will secure it with something that can hold it all round, because the higher the surface area connecting to the patient's exit, the better the safety. Okay? Finally, if it is a very hairy structure, a hairy surface like this is hairy. If I put it here, then this will stick to the hair but not to the skin that well. When there is a distance between the hair and the skin, and this is attached to the hair, what will happen? You will get burning of the hair. You'll get singeing of the hair. So when you remove this, at the end of it, you will feel like there is burnt hair smell. So it is not supposed to be applied over a hairy surface. If you have a hairy surface, thigh, whatever, you shave it off and then attach this. Clear? Another rule, you do not apply it over hollow surfaces like the popliteal fossa. So if you have this hollow surface, don't go and put it here. There is lack of contact there. You have to put it over a normal surface. Try putting it over an area that has more muscle. Why? Because muscle has a better resistance. If it is a very fatty area, then there is a higher impedance or resistance, and you will have a higher chance of the current trying to look for alternative exits. So a muscular area, gluteal area, the thigh would be very good. The abdomen is actually not a very good surface. This has a lot of fat area, fat tissue. And lastly, if you have tattoos on the patient, then try to avoid the tattoo areas, because tattoos are essentially metallic dyes, and they therefore would have a higher chance of getting heated up as you're doing it. So that comes to the rules and regulations about return electrode. So with this, friends, we come to the end of episode 1 or part 1 of the electrosurgical marathon classes. So I would be discussing in more depth about the different electrosurgical modes and the effects, and then about the hazards of electrosurgery, and then as we move on further to bipolar energy, advanced bipolar energy, and ultrasonic energy. See you next time.